I facilitated an IDG that was looking at clinical capacity that sits around virtual wards or virtual care in the round. And there were a couple of key discussion points. One of them is who takes clinical ownership of these patients. There is a tendency at the moment for the acute consultants to have ownership of these patients, very much based on that step-down model of care. But in line with the guidance that we need to shift care out into the community setting, we need to be thinking much more about how can community workforce be enabled and empowered to take clinical responsibility, and how and when do those clinical responsibility lines be divided. So when you're looking at a patient that's sat in the community but needs to step up into the acute, how do you enable that transition between the two? And then second, and I think it's an adjunct to that, is how do you support a workforce that is really stretched already? Some of the ideas that came to mind were thinking about the other specialties that sit within an MDT that might be able to support. So looking at social prescribers and health coaches and other really interesting healthcare professionals who might be able to add and augment the clinical workforce within virtual wards.